Okay, good evening, everyone. My name is Dorian. I'm one of the members of the British Caribbean Doctors and Dentists Association. Welcome to our talk on Your Heart, Your Health by Dr. Winston Martin. But before I introduce Dr. Martin, I want to introduce you to our chairperson or our founder, Dr. Rochelle Pierre, who's just going to tell you a little bit about our organization and what we do. So I'll hand over to Rochelle.
Hi everyone, as Dorian said, my name's Rochelle and I'm the chair of the British Caribbean Doctors and Dentists Association. First of all, I just want to thank everybody for joining us this evening, and also thank Dr. Martin for joining us. I hope it will be an insightful evening for everyone. I just wanted to tell you a bit about the organisation. So we are a group of Caribbean heritage doctors and dentists that are based in the UK. So I founded the organisation in 2019, and the idea was basically to bring those of Caribbean heritage together to increase visual representation of Caribbeans in medicine. And also to sort of raise aspirations of young Black children within the UK and hopefully push them in towards a career of medicine or dentistry. Some of the other aims that we have with the organisation is, one of them is health promotion. So this event falls under our health promotion team, which Dorian will tell you a little bit more about, but we want to improve sort of the health literacy within the Caribbean community and just empower people to sort of take care of their health and to understand certain things within medicine that, you know, we don't often talk about. Other things are sort of outreach work where, as I mentioned, we want to reach out to young people and try to help them achieve a career in medicine. But we also want to support those who are already within medicine and dentistry through mentoring and forming a peer network just so that we can support each other. The organisation is a not-for-profit organisation, and we are at the moment going through the process of registering to become a charity. So we are putting on these free health promotion events, but if anybody feels that they would like to donate to the organisation to help us reach our charitable aims, then we will post a link throughout the talk. And yes, feel free to donate if you wish to. So once again, thank you everyone for joining. I'll hand back to Dorian, who will take you through the event and introduce Dr. Martin. I hope you enjoy it. See you.
Hello again, everyone. All right, so just to introduce a little bit about the health promotion team, what we're planning to do is basically we're trying to host at least each month a topic to try and just encourage people in looking after themselves. So this month, it was Heart Month. And so we shared a video about high blood pressure and hypertension. That's on a lot of our social media at the moment. And what we're hoping to do as well is next month is Oral Health Month. So we're also having an event next month as well. So we look forward to inviting you all to that. So what I'm going to do now is I'm going to introduce Dr. Winston Martin. So Dr. Martin, he currently practices at the Kim's Hospital in Kent, where he is a cardiologist. He has a really specialist interest in angiography and stenting and looking after people with coronary heart disease and people with hard to treat high blood pressure. So Dr. Martin is going to tell us today about the risk factors, the symptoms, the complications, and the treatments and preventative measures for heart disease, especially in the Afro-Caribbean community. So without further ado, I want to welcome Dr. Martin to give us our talk, and I hope everyone enjoys it.
Thank you very much, Dorian. And thank you to Rochelle and to Whitney for inviting me to this excellent forum, which I hope will grow and develop over the months and years. We've seen how COVID has kind of spotlighted the inequalities that our communities suffer, and the importance of addressing some of those issues, which hopefully I'll touch on this evening. Thank you all for all of your attention, joining on a Saturday evening. I guess we're not struggling against other particular activities, as we're all still kind of locked down. So we've got your undivided attention, and hopefully you'll enjoy the next kind of 40 minutes of my talk. And then there'll be opportunities to kind of pose some questions and answers, which I hope will be very stimulating, interactive, and hopefully draw out some potential other topics that people might be interested at a later stage. So if I go to, can everybody see my slides? I just double check, is that okay?
Not yet.
Okay, let me just make sure that just go back. Let me just share my screen and then I'll get started. Can everybody see that now?
Yeah.
Excellent. Okay. New technology, still on Zoom land. Okay. I think we've got some interference. Somebody sounds like they're in the hurricane. Oh, that's better. Okay. So, as Dorian has mentioned, my name's Winston Martin. I'm a cardiologist. I practice in the NHS at Darent Valley Hospital in Dartford, and I also have a private practice in Mid-Kent in Maidstone as well. This is the Heart Centre at Darent Valley, a purpose-built facility which was opened back in 2007, and the cath lab that you can see on the lower right has actually undergone a refurbishment. So this is the old one. I need to get some new stock images. But this is where we do kind of some of the business work, looking at people's heart arteries and putting in pacemakers. This is me and some members of the team performing angiography on patients who have suspected heart disease, typically chest pains, angina, heart failure. And as I said, my other colleagues assess patients who have rhythm problems, maybe causing palpitations and other forms of heart disease. So just as an introduction, I'm a cardiologist because when I was at medical school and during my early days as a junior doctor, heart disease and the heart really kind of took my attention. The heart really is quite an amazing organ. It's a marvel of evolutionary engineering. Its function is to pump fresh blood, fresh oxygenated blood around the body, and bring deoxygenated blood back to the lungs to be replenished. It is highly efficient and very reliable compared to anything made by human beings. The heart is visible fairly early on in embryonic development. Here's a kind of diagram of the heart here, situated just under the head, next to the neck in the embryo. And contractions begin at day 22 after fertilization, so less than 4 weeks after fertilization and conception. And blood circulation through the developing embryo can be observed by the end of week 4. And the heartbeat then beats continuously in most humans, fairly regularly, for up to over 80 years. And increasingly, human beings are living longer, and we now have several humans living well into their hundreds, and a couple heading towards into their 110s, which is really quite incredible. And over that lifetime, the heart beats over 3 billion beats. So I say it's really quite an incredible organ. And here's an embryo. This is the heart here. And as I said, it's already started beating. And you notice its position in the neck, which then declines as the embryo grows. But it's this relationship of the heart to the jaw and the neck and the upper limb here, which explains why patients who experience heart pain, angina, experience it in the neck, around the jaw, and often what we call radiates into the upper arms. It's because the nerves that supply the heart are actually arising from this area. And the heart then descends into the chest, taking those nerves with it, and then it becomes located in between the lungs, in the center of the chest. But the heart starts off really as a curvy tube, and this tube undergoes various twists and turns and divisions, which then give rise to the 4-chamber structure that we recognize in the adult. Exactly how these changes are coordinated are still not very well understood, but we know occasionally that these complex changes can go wrong. Sometimes if the embryo is infected by viruses such as measles or rubella, then that can result in what we describe as congenital heart disease abnormalities. And these structural abnormalities can result in what are often described as holes in the heart, narrow tubes, what we call constrictions or stenoses, or indeed sometimes even absent chambers. And these are described in the newborn as causing congenital heart disease. And over the years, over the last 30 years, doctors have become better at managing congenital heart disease, so that we now have many adults who have underlying congenital heart disease surviving through to adulthood, and in themselves now being parents and creating families. As I said, the heart, when it develops normally, is a 4-chambered, 2-sided pump made of specialized smooth muscle cells. And there are a series of valves which separate the main chambers. We have the top chambers called the atria, which collect blood from the lungs and from the body, and then the main pump chambers at the bottom, the left and right ventricles. And the valves ensure that the blood flows through the heart in the right direction. And if there's an abnormality of the valves, whether there's narrowing, commonly of the aortic valve here, or leaks, typically of the mitral valve, then that can cause abnormal blood flow and in itself lead to heart symptoms. The right heart is responsible for collecting what I described as used blood. So that's blood that's already been through the various organs of the body, typically from the head, from the brain, and from the lower body, and pumping it to the lungs. And then the left heart, here designated in red, brings back the nicely oxygenated blood into the left heart and then pumps it through the aortic valve, and that gets distributed around the rest of the body in order to supply the various organs. Again, the brain, which is very oxygen hungry, our body, our limbs, and the internal organs, typically our gut, liver, and our abdomen and our muscles. What's important to recognize is that the heart needs to have its own blood supply. And this is achieved through what are described as the coronary arteries. And these feed blood just above the aortic valve, feed blood into the vessels which run over the surface of the heart. And there are penetrating vessels that run into the heart. We describe the coronary arteries because they circulate around the outside of the main heart structure and give off these branches, hence why we get this description of the crown, and hence why we call these vessels the coronary vessels or the coronary arteries. The other important feature of the heart is that it pumps, and in order to work properly, it has to pump in a coordinated fashion in order for it to be efficient. And we have various phases. We have what's called diastole, which is the phase of filling of the heart, blood flowing in from the lungs and in from the rest of the body into the main pump chambers. And then we have systole, where the top chambers contract, pushing blood into the bottom chambers. And then we have ventricular systole, where we get the heart, the main pump chambers, pumping blood towards the lungs in order to get oxygenated, and oxygenated blood around the rest of the body. So these kind of 2 or 3 main phases described as diastole, which is generally filling of the heart, and systole, which is contraction of the heart, which results in the actual distribution of the blood. And it's important that this happens in a controlled fashion and it's regulated, and that regulation is controlled by the main pacemaker. So we have a pacemaker which is situated towards the top of the right side of the heart. And we have these specialized muscle cells which act as conducting fibers or wires, which then transmit the electrical signal towards the junction box called the AV node, which is like the central junction box, and then transmitted through to the main pump chambers. And we have this schematic diagram which helps to simplify it. And normally there's a fibrous ring which stops the electricity coming from the top chambers and distributing itself erratically over the rest of the heart. And the aim is that the fibrous ring stops the electricity coming from the pacemaker and going to the rest of the heart. And it's only allowed through this central junction box. And as a result, we get this coordinated electrical signal, which then passes through into the main pump chambers of the heart, giving rise to the electrical signal, often termed the ECG or electrocardiogram, that we can record. And that provides huge amount of information about the function of the heart, and is often one of the first tests that are undertaken if one goes into hospital with any concerning medical issue, medical problem, particularly if you're reporting chest pain or palpitations. And I say it provides a wealth of information, not just about the heart rate and the heart rhythm, but also the state of the heart muscle itself. And if there are abnormalities of the heart muscle, if, for instance, the heart muscle is scarred or it's thickened, then we see changes in these various parameters, which, as you can see, are quite detailed. And very often, a junior doctor will spend a great deal of time examining ECG together with their senior colleagues in order to gain as much information about your heart if you're admitted to hospital. And I say, with modern equipment now, a trained person can perform a 12-lead ECG within 5 minutes. And I say, an enormous amount of information can be gained very quickly. And increasingly, GPs in primary care are recognizing the benefits of having this technology in their GP practices, and very often arrange for patients to have an ECG as part of their assessment, particularly with common conditions such as hypertension or high blood pressure or diabetes. As a result of all of the features of the heart that I've described, heart disease, as you can imagine, can occur in many forms. As I've mentioned already, we have the issues of holes in the heart, narrow tubes, absent chambers, which constitute congenital heart disease. We also have conditions of the heart muscle, thickened heart muscle, a common cause being high blood pressure, fatty heart muscle or fatty heart muscle change, which can occur as a consequence of some genetic abnormalities, sometimes occurring in young people and young adults, which can result in sudden death, such as happened to Fabrice Muamba, who thankfully was able to survive sudden cardiac arrest on the football field now around about 8 years ago. And we also have these abnormal, what are described as ion channel conditions, where the flow of chemicals such as sodium and potassium and calcium are either blocked or are kept open too long, which can cause rhythm abnormalities, which can also cause heart rhythm abnormalities and result in heart rhythm death. Perhaps more commonly, though, we have the conditions of the blood vessels going to the lungs, where you can get clots which block the lung flow, blood flow into the lungs, and also a condition we call primary pulmonary hypertension, which is commonly associated with conditions such as arthritis, scleroderma, lupus. Again, we have the conditions of heart rhythm abnormalities, a common one being atrial fibrillation, which I'll come to in a bit more detail later. I've mentioned high blood pressure, and very often this is associated with dyslipidemia, and we know that patients with diabetes often have high blood pressure combined with particularly sticky cholesterol. Even if it may not be particularly high, the cholesterol is often very sticky, and the combination of high blood pressure pushes the sticky cholesterol against the vessel wall, and that gets absorbed by the blood vessel to lead to conditions such as atherosclerosis. Atherosclerosis in the coronary artery leads to thickening and development of plaque tissue, which can rupture, leading to heart attacks. And we know a similar process can occur in the carotid arteries, which can give rise to stroke. We also have conditions affecting the valves, as I've mentioned, common ones being aortic valve stenosis or narrowing, or mitral valve regurgitation or leakage, which can result in strain on the heart, causing the heart to become thickened or weaker, causing conditions such as heart failure. And we know that heart failure is extremely common amongst the African and Caribbean community. Again, one of the commonest causes being hypertension, diabetes, and kidney disease. The consequence of heart disease is that it can cause heart pump failure, and that can result in a syndrome characterized by breathlessness, decreased exercise ability, tiredness and fatigue, and fluid retention, leading to body swelling, often swelling of the feet. If fluid builds up in the body, that can lead to difficulty in sleeping. So very often, people are forced to sleep upright in bed. And if that continues, often they're unable to sleep in bed and end up moving to a chair to sleep. The swelling can also lead to swelling of the abdomen, particularly also of the liver, causing pain, particularly in the right upper quadrant of the abdomen, swelling of the gut, leading to loss of appetite. Fluid buildup in the lungs leads to cough, and that fluid often returns up from the feet when people lie down at night, resulting in increased stress in the kidneys and increased urination. So people get up in the middle of the night in order to pass urine. And with reduced pump function, very often that can lead to confusion and impaired memory. And this is a typical picture of somebody who has heart failure and is one of the commonest causes for admission to hospital, and can often result in long stay in hospital in order to be given diuretic therapy and started on potent medication in order to help with heart pump function. And one of the signs that a junior doctor will look for is this increased distension of the upper vessels in the neck and swelling of the feet and ankles. And we also now recognize that heart failure isn't just a problem of contraction of the heart, as in during systole, but is also a problem of filling of the heart. And increasingly, one might hear terms of heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, where the contraction of the heart appears to be normal, but actually it's a filling problem which leads to the symptoms. And in addition to the heart pump failure, again, heart disease can lead to abnormal heart rhythms. And we know that pump failure itself can result in abnormal heart rhythms or arrhythmias, and arrhythmias can also lead to pump failure. So there's this kind of swing between the two, which can often result in conditions, both conditions being present in the same patient. One of the commonest rhythm abnormalities is atrial fibrillation, and we know that that's a condition which is associated with an increased risk of stroke due to clot formation within the abnormally contracting top chambers of the heart. And the clot then can be flicked out of the heart, leading to the presence and the development of stroke. And we know that patients with heart failure and atrial fibrillation are at much increased risk of stroke. We also know that certain heart rhythms can lead to premature or sudden death. And again, patients with heart failure often have a propensity to ventricular arrhythmias, so rhythm abnormalities of the bottom chambers of the heart, which can also result in sudden death. It's important to recognize that the heart is really just in the center of a distributed circulatory system. We've mentioned the lungs, but importantly, issues with the heart can have effects on the kidneys, and also effects on the kidneys can have feedback effects on the heart. And the heart also supplies other organs within the abdomen and of the various limbs, and importantly, the brain. So one can see how issues of the heart can affect other organs around the body. And as a result, we do recognize that cardiovascular disease is a leading cause of death in England and Wales in the UK, and accounts for 1/3 of all deaths. And the latest kind of figures go back to 2010. There are some more up-to-date figures coming over the next year, but this gives you an idea of the numbers of annual deaths related to cardiovascular disease. And very often, a significant amount of that kind of death burden occurs in patients actually under the age of 75, people who we would now consider to be relatively young, given that really most patients should be living well into their 80s now. So clearly, this is the burden of premature death, and we know that African and Caribbean people are some of the biggest contributors to that relatively premature death burden. And a significant number of those patients are typically men. So this diagram demonstrates that coronary artery disease is really just one group. It is a large group, but it is just one group of all the conditions which get labeled under cardiovascular disease. Stroke is a particular condition which affects African and Caribbean people. And then there are other cardiomyopathies, rhythm abnormalities, vascular dementia, arteries of the arterioles, such as vasculitis, including lupus, vascular disease directly due to hypertension, and some of the more small print issues, such as rheumatic heart disease, which is still a condition which affects many patients in Africa and sometimes in the Caribbean, and some of the congenital abnormalities, which I briefly mentioned. Although we've seen a gradual reduction in the death related to heart and circulatory diseases, this is starting to flatten out now, and it's a concern that we may still have a significant burden of cardiovascular disease in the future, particularly as we see some of the particular risk factors which I'll discuss with respect to obesity and diabetes, which are unfortunately on the increase in the UK, again, particularly affecting African and Caribbean patients. And although I've mentioned that annual death rates are close to 200,000 now, we know that cardiovascular disease represents a huge burden of long-term illness and disability. And this affects both the elderly and also people of working age. And it's estimated that around 4.5 million people in England and Wales suffer as a result of vascular disease, which affects their ability to work and to lead a high quality of life. And this burden is in the region now of close to £9 billion a year, a lot of which relates to inpatient care, small amount to medicines, outpatient and primary care. So one of the major efforts over the next 10 years by the NHS is to reduce the burden of cardiovascular disease and they've kind of separated stroke out in order to prevent both heart attacks and strokes and the development of dementia over the next 10 years. And so a great deal of the priority areas are focused on cardiovascular disease management, but also prevention. So I'm just going to touch on one area of disease, and that's atherosclerosis, because it really underlies the kind of end product of some of the risk factors that we see in patients in the Caribbean, of Caribbean parentage in the UK. We know that fatty disease develops early on. Studies in America back in the 1950s suggested that we can see these early plaques in the aorta, the main blood vessel coming out of the heart, in people in their late 20s, early 30s, and then they gradually develop over time, resulting then in these effectively what I would best describe as chronic abscesses within the vessel walls. And if these occur within the coronary vessels, you can see how they can start to obstruct the flow of blood. And if then on top of that, you get rupture of these plaques, then you can get sudden clot formation, leading to blockages, leading to occlusion of the heart vessels. And so I always encourage my trainees to think of coronary plaques as slowly developing cholesterol-laden abscesses. And one would want to try and treat those before they develop. And that's why there is a lot of focus on the use of cholesterol-lowering tablets in both secondary prevention, so reducing the risk of heart attacks in people who've already had heart disease, and in primary prevention in preventing development in patients who have heart conditions such as high blood pressure. And high blood pressure is the force of blood pushing against the blood vessel walls as the heart pumps blood into the arteries, and the arteries carry blood through the body. And we need a certain amount of blood pressure in order to facilitate that distribution. But if the blood pressure is very high, then that can lead to stiffening of the blood vessels, and you get thickening of the region called the intima, and also of the muscle cells and muscle layer that surround the lumen of the artery. And as this muscle layer becomes stiffer, that can result in development of high blood pressure. And we know that there are certain conditions which can increase the blood pressure. So exercise actually increases blood pressure, but in a good way. But if one is chronically stressed or chronically anxious, and often the two go together, that can lead to increased elevation of the pressure, which doesn't settle. And that increased tension in the blood vessel leads to thickening of the blood vessel, and ultimately can lead to thickening of the heart muscle. We also know that increased stress can lead to excess salt intake, leads to excess salt absorption by the kidneys, and that results in abnormal hormone production, particularly of something called aldosterone, which comes from the adrenal gland. And that results in increased resistance in the smaller vessels called the arterioles, and hence to thickening and narrowing and hardening of the arteries, something we call arteriosclerosis. And we know that there's a complex system that controls the blood pressure, and we know that that feeds back both to the brain and from the brain back to the arteries, And we know that these hormones as well also influence the way in which the blood vessels are control the blood pressure. And as the vessels become hardened by the deposits of cholesterol, these can turn into calcium and lead to hardening of the heart arteries. Hence why we examine people. One of the first things we do is assess their blood pressure, see if their blood pressure is elevated. And we tend to describe high blood pressure in people where the blood pressure is over 140, over 90. There is a view that possibly because of the increased propensity to high blood pressure in people of African and Caribbean parentage, that we should consider a lower blood pressure level, maybe even 135 over 85, as when we should consider them for treatment, sometimes with lifestyle changes and with medication. And particularly if the blood pressure is greater than 160 over 100, well, that often is an indication specifically for drug treatment. And as I said, high blood pressure can lead to heart disease, can have adverse effects on the kidneys, given they've got very sensitive nephrons and glomeruli, which filter the blood. We know that it has a powerful effect on the brain, leading to stroke, can also result in eye disease, and as I've said, atherosclerosis elsewhere. So I said this is a diagram of the kidneys, and if you look in detail in the kidneys, you have these glomeruli, which are little filtering units, and these filtering units are very susceptible to the effects of blood pressure, and that can lead to leakage of protein, which then fills the space of the collecting nephrons and leads to reduced filtration and development of kidney disease. And we know that causes of high blood pressure come in various guises. So we know lack of regular exercise itself can lead to high blood pressure, being overweight, excessive salt intake in the diet, smoking, excessive alcohol drinking, and stress. And we've seen that COVID-19 has shone a light on, in terms of risk of disease in both African and Caribbean people. And the view is that the chronic stress related to racism may be a particular factor which contributes to the propensity of Black people towards the effects of COVID-19, both in terms of actually contracting the disease, maybe because of the various occupations being on the front line, both within healthcare, within transport, and within other industries, but also then the adverse effects when they've actually contracted the virus, because we know that the virus has a particular attachment which attaches itself to certain receptors which are probably elevated in people of chronic stress, particularly those with high blood pressure and diabetes. We know that chronic kidney disease can feed back on the blood vessels and feed back on the heart and result in high blood pressure. And again, we know that diabetes can also affect the kidneys, again, contributing to heart disease. We know that also conditions, endocrine conditions such as thyroid disease and adrenal gland disease can also affect high blood pressure. And we know there are some genetic conditions which also cause hypertension. So when we try and look at all the various causes or contributors to death from cardiovascular disease, we know that high blood pressure contributes a significant amount. We know that smoking does, and smoking cessation over the last 10 years has actually significantly reduced the incidence of heart attacks, and we saw dramatic changes very quickly, just go back, very quickly within several weeks to months after the smoking cessation laws changed about a decade ago. We also know that cholesterol contributes significantly, but interestingly, inactivity probably contributes almost as much as cholesterol. There is a contribution from obesity, but also there's a large area which we still don't quite understand, whereby perhaps again stress, and again stress specifically related to racism, may be particularly pertinent to people of color. This is an interesting graph which shows where the UK is in terms of age standardized death rates. And if you look, you can see that the UK, Finland and Ireland, so these are countries within Europe which tend to be within the more northern latitudes. And if you look in countries which are closer to the Mediterranean, France, Italy and Spain probably benefit from greater exposure to sunlight. And this raises the question as to whether vitamin D may be a particular factor as to why in the UK we are more prone to cardiovascular death. Yeah. And again, in particular, people of color, again, may be particularly at risk because we don't make sufficient amounts of vitamin D, limited only to the summertime. And as we know, the summer can be very short. And again, if we're not exposing our skin to the sunlight, which is typically a situation in Black communities who may not have the ability to go abroad on holiday, and even if they do, are not generally predisposed to exposing their body. So again, we may be particularly prone to vitamin D deficiency. And one of the lessons I would kind of ask people on tonight's or watching this tonight's program is to ensure that are taking sufficient amounts of vitamin D. It's a cheap thing to do. Vitamin D is readily available from your local supermarket, from Costco, and may be highly beneficial in terms of contributing to cardiovascular health. And I'd recommend generally about 1,000 units a day. And for most people of color, it's probably something that it should take on a daily basis. Just touch on briefly now on diabetes. This is a condition which is growing particularly problematic within the Black community. We know that 1 in 11 adults globally have diabetes. As a result, over the next 30 to 40 years, nearly over 600 million people across the globe will suffer with this condition. And it's particularly pertinent in low and middle income countries. And about 30 to 80% of people with diabetes are undiagnosed. And the particular problem about diabetes is it has multiple effects. It affects both the heart pump, it affects the kidneys, and affects the blood vessels. And as a result, it can have these multitude of effects: heart failure, stroke, heart attack, increases the risk of amputation, sight loss, and kidney failure. And all of these are conditions that we see more of in Black people. And the important issue is that people with diabetes, 2/3 of people who die of diabetes die as a result of cardiovascular disease, not due to the actual high sugar levels, yeah, although that contributes to the aging of the tissues, but it's actually the effects of sugar on the cardiovascular system. And if you were to take somebody 60 years of age, they would expect to live at least 20 years, as I've mentioned, well into their 80s. But if you have diabetes, very often that will be shortened by often at least 6 years. And if you have diabetes and cardiovascular disease, then your longevity is shortened by 12 years. So you'll be lucky to live to reach 70. And it's because of the various contributing risk factors that lead to diabetes, high sugar levels, obesity, high blood pressure, and the effects of elevated cholesterol, that diabetes has its effect. And it's important to realize that by the time you're diagnosed with diabetes, it's almost already too late. We know that cardiovascular risk increases even before you're diagnosed with diabetes. So when you're pre-diabetic, yeah, so when you already have the changes often associated with being overweight or obesity, even if you're not diabetic, we already see some of the adverse effects on the cardiovascular system. And this is some of the latest data with regards to weight and obesity. And sadly, we see that high numbers of men and high numbers of women are overweight or obese, yeah, well over 60%. And we can see that this is going to be a significant problem. And amongst the various income groups, we can see that the poorer you are, the higher the risk of having obesity. And here we see in communities most deprived, which sadly include people of Black parentage, yeah, then we are more at risk of both obesity and the attendant risks. And here we see, particularly in the Black community, extremely high prevalence levels of obesity, both in men, but particularly in women. And this is an area which we're going to need to tackle as a community. Sadly, we also see this in our children. So this is obesity status, BMI status at reception when children arrive in school. And again, nearly 20%, 25% are obese or overweight. And that actually increases by the time they reach year 5 or year 6. And again, when we look at obesity levels in children by ethnic group, we see that Black Caribbean and Black African represent a significant prevalence, yeah, and those of mixed race. So this is an issue which is particularly pertinent amongst our community. So this is something we're going to need to tackle if we're going to reduce the effects of diabetes and obesity directly on cardiovascular health. And if you're in your 40s, then one may well receive invitations to attend for heart checks. And it's important that one attends to these so that various issues can be identified. You can have your blood sugar levels checked, your blood pressure checked, cholesterol levels, blood tests done, and then advice regarding exercise, healthy eating, and smoking cessation, which is not a particular issue. It is an issue, but is in terms of prevalence, it's really obesity that is a particular issue amongst our particular community. And it's important that we pay attention to the right dietary choices, that we exercise. The human body is designed for movement, and we're recognizing that being sedentary, particularly if one's working in occupations where one's sitting either particularly in transport, taxi drivers, bus drivers are particularly at risk. And again, these are occupations where our community are working at high levels. And it's important that any exercise is important. The more that we can do, the less our bodies will be at risk of obesity and particularly high blood pressure and diabetes. And there was the program several years back, which again is likely to have great importance, particularly given the situation as we come out of lockdown, where many of us have not been able to go to the gym and movements outside the home have been restricted. And it's going to be vital that we again encourage our community to get back on their feet, exercising as much as possible in order to counteract some of the adverse changes that have occurred over the last year as a result of the COVID pandemic. I'll end there and open up the floor perhaps to questions, and we can, like I say, discuss some of the issues I've raised and answer questions from the audience. Many thanks.
Thank you so much, Dr. Martin. So yes, your talk has been very, very interesting. And as it is always with interesting talks, there are a lot of questions. So clearly people have really been motivated by what you've been saying and have been asking some really interesting things to follow up. So I'm going to take that off, that's fine. So first question that we have for the evening is, what are some of the reasons behind the higher prevalence of cardiovascular disease among Black, African and Caribbean people?
So as I've mentioned, I think it's multifactorial and it's complex, but we do know that reduced lack of exercise, obesity, as I've mentioned, perhaps exposure to chronic stress, and particularly the chronic stress related to racism, have been highlighted. And we know that even if you have people of different ethnic groups, ethnic origins within the same occupation, people of Black origin will still have worse outcomes as a result of cardiovascular disease. And let's say the role of chronic stress is now has been highlighted by COVID-19. Just before the pandemic struck, the NHS started to recognize this, and they've created what's described as the NHS Race and Health Observatory, which has a board made up of a range of kind of leaders within the Black community, Black and wider ethnic community, which will hopefully start to look at and develop research, look at the evidence, and hopefully produce policies which will tackle some of these inequalities and provide guidance for organizations, not just the NHS, but organizations more broadly in a wide range of industries, so that this particular issue of inequality can be dealt with in a proactive way.
I know there's a US professor who's looked into this in a lot of detail about microaggressions and how that negatively impacts our health outcomes. Another question is, has anyone investigated why the NHS might give substandard cardiac treatment to African and Caribbean patients?
That's a very good question. I think in the past, there was a view that Black people didn't suffer heart attacks. There was a general view that heart attacks only really affected people of what was described as kind of class A or type 1 personalities, so business people, high rollers, peoples of industry, that indeed women never suffered with heart attacks. we know that really it's completely the reverse, and that actually it's people who are of in occupations where they have lack of control as to their workload, who may have to travel long distances in order to get to work, who may indeed have to work several jobs in order to make ends meet. Yeah, that probably all contributes to that higher risk. As well as looking at those specific personal issues within a particular person, their blood pressure, their weight, we know that we're not really going to tackle the problem unless we look at the more broader structural issues within our environment, within our community, that prevent us managing our own, indeed, finances, our own economic development, and our own well-being. So those are areas which are going to need to be tackled, and something that the community is probably going to need to embrace and tackle ourselves. It's not really going to be something that other people are going to do on our behalf for us. It's something we're going to have to fight for and to develop. And that's where, you know, community groups within churches, within organizations such as this one, the BCDD, you know, will be important leaders in making sure that, you know, our community gets the respect and indeed the funding in order to break some of these inequality barriers that it faces.
So another question is, I've heard there's a connection between heart disease and dental health. Is this correct? And what can we do to help ourselves?
So on a direct basis, we know that there are conditions such as infective endocarditis. That's an infection in the heart, often on the valves, where the commonest source of infection comes from the teeth and from the gums. Yeah. And particularly in patients such as those I mentioned with congenital heart disease, or those with valve disease, yeah, where the bacteria like to latch onto these abnormal areas and set up infection. But more broadly, we know that gum disease and tooth decay occurs more commonly in communities with reduced health outcomes, where the diet is not good, where it's high in sugar. And we know that probably the inflammation related to the gum and tooth decay actually creates inflammatory changes. And these inflammatory changes affect the blood vessels and thereby affect the cardiovascular system, the blood vessels, the kidneys, and the heart. So it's a complex interplay, but we know that actually good dental hygiene, getting your teeth checked regularly, is vitally important to your general health and well-being.
Okay. So a question today, people, obviously it's quite topical. We've been told about how COVID-19 affects the lungs, but we are hearing that it also affects the heart. Can you explain in what ways COVID-19 affects the heart? Yeah,
it's a good question. So COVID-19, when the virus, the SARS-CoV-2 virus, is contracted, it's commonly contracted by inhaling, so breathing in the virus through your nose, through your mouth, and so the very first organ that's affected will be your lungs. And the vast majority of the virus particles hits the lungs first, and it gets absorbed through the lung tissue into the pulmonary vascular system. So these small blood vessels that surround each of the lung sacs, hence it causes what's described as a probably termed a pneumonitis, inflammation of the lung, those very fine lung vessels. But we know that the virus then gets transmitted to other organs. The first organ it will come to is the heart. And there's a view that the virus can affect the actual heart muscle itself, causing myocarditis. We also know that it also increases the risk of clot formation. And many patients with COVID often have elevated clotting levels, often identified by a test we call the D-dimer. And we think what happens is that the influence of the virus in the cells leads to reduction in protective factors which protect the vascular lining, what we call the endothelium. And as a result, we get this condition called endothelial dysfunction. And the endothelium is the barrier between the wall of the vessel and the flowing blood. And if the endothelium is affected, then the platelets in the blood start to get activated and they stick to the endothelium, and that then sets off this clotting process. And obviously blood vessels are present, as we said, around the heart and the coronaries, so it can lead to coronary occlusions and heart attacks. We realize that it can occur in the vessels almost within the lungs themselves, causing pulmonary thrombosis in situ, but also increases the risk of clots in the leg veins and what we call pulmonary emboli, which fly off into the lungs, causing blockages of the lung vessels, which in itself can cause strain on the heart. So we think COVID-19 affects many organs, and we've seen patients who have clotting of their fingers. We also know increased risk of stroke. So it's multifactorial, and COVID is an awful disease and something that is best avoided. And we know that the vaccine has proven to be very effective and does reduce the risk of probably, certainly severe illness, and probably reduces and protects the lungs from actually contracting the virus itself.
Okay, no, thank you for that. Next question I wanted to ask about was, people mentioned about, in the stats you talk about being overweight. Do you mean being over fat, or does being overweight include those with higher muscle masses?
Yeah, so there are always criticism about the role of what's described as the body mass index, which is effectively your weight divided by your height, in a sense. It's slightly more complex than that. It's kind of, it includes your body surface area. But and clearly those who are very muscular will often have increased weight. But the issue then becomes, okay, if you're very muscular, how does that develop as you get older? Does your muscle still function as muscle, or does it become kind of fatty? And how well do you maintain the activity in order to maintain that muscle as you get older? So yes, there are criticisms about whether being muscular protects you, and it probably does, and it probably protects you from diabetes. But as a general rule, the higher your BMI, then we do recognize you are at increased risk of the effects of diabetes and high blood pressure. And it's something to monitor as one gets older.
Okay. Well, thank you for that. Okay, I'm going to go. Sorry, there have been so many questions. So I was just trying to make sure I didn't ask the same one twice. There's someone here who said, I've been told I've had LVH. What's your advice in terms of lifestyle changes? Can it be improved or reversed? Sorry, by LVH, he means left ventricular hypertrophy, which is thickening of one side of the heart muscle.
Yeah, no, so so Black people do tend to have, as a group, thicker heart muscles. And we can measure it quite accurately by echocardiogram, and also increasingly in circumstances where necessary by MRI, very accurately. What we do know is that the higher your blood pressure, the more propensity to the heart muscle to thicken, almost as a reaction to the stress that the heart is under. And we know that Black people thicken their heart muscle more easily and quicker compared to other ethnic groups. And when we look at heart muscle thickness, we know that that is an independent risk factor for other conditions such as kidney disease and stroke. So despite the fact, yes, as a group, we have thicker heart muscles, we tend to have worse outcomes when we have high blood pressure because our heart muscle thickens more, and that increases the risk of poorer outcomes. In terms of, is it reversible? Yes, it is. By reducing the stress on the heart, reducing the blood pressure, we can actually detect changes over months and years. So good blood pressure control, particularly during the nighttime, where many people have elevated blood pressure still. If we can control it, particularly during the night, then we see quite dramatic resolution of that heart wall thickening. And as a result, if we see heart wall thickening on an echo when you're assessed, we often want to try and drive the blood pressure down even further than we would in people without heart wall thickening.
Following on from that, so somebody's asked about lifestyle choices and the kind of lifestyle interventions that you think people could make to try and make a difference to things like high blood pressure and heart disease in general.
So, I mean, the first thing to do is really to be walking more. Yeah. It sounds kind of a silly phrase, but you know, we do know that being on your feet and being active does have direct benefits. Almost as soon as you sit down, your body kind of goes into a kind of rest mode, and if you sit down for too long, it almost goes into a kind of sick mode, and glucose levels start to rise, and that starts to have adverse effects. And increasingly, we think that glucose, particularly large amounts of glucose, start to influence how your pancreas reacts. That increases the amount of insulin secretion, and you get increased insulin, which in itself causes a feedback loop to result in abnormal changes in blood vessels and in the heart. So being active cannot be underestimated, and walking is important, but any form of exercise, I would certainly encourage people to, if they can, to learn to swim. Swimming is a kind of all over body exercise. It's a good skill to have, and avoid putting excess weight through your joints. And it's very hard to injure yourself by swimming. So it's something that I do encourage people to undertake, particularly those who are more overweight, where sometimes walking, running, jogging may not be doing their joints any favors until they've been able to lose the weight. So it's an important form of exercise. In terms of other choices, reducing the amount of carbohydrate in your diet, again, is important. As a rule, we generally overeat, so we eat more than we need, and that then accumulates very often in the form of fat, particularly around our waist and within our abdomen. And we know that that fat around our organs in our abdomen, again, increases the risk of inflammation and adverse effects on our blood vessels. So exercise and diet, and combining that in terms of maintaining normal weight is very, very important long term.
I appreciate that we have actually already overrun our time. We're supposed to finish around 8 o'clock. I mean, I hope you're still happy to answer. There's still a few questions.
Yeah, sure. Yeah.
To answer some of those questions. Thank you. All right. The next question is, so this one is about, you mentioned about vitamin D, and I think, well, a lot of us are, have heritage from the Caribbean or born in the Caribbean or have family where there's lots of sunshine, lots of vitamin D. So the question is asking about vitamin D and cardiovascular disease. Has there been any comparative study done on this between sort of people in the UK who get, well, Black people in the UK who get cardiovascular disease and people in or more equatorial climates or tropical climates where you have quite sufficient vitamin D? Are the cardiovascular outcomes similar, or do we get heart attacks at the same rate? Sorry.
We don't. There definitely is something about migration which influences our outcomes with respect to cardiovascular disease. Vitamin D is probably a part. As I've mentioned, the effects of racism and chronic stress that accompany migration probably overall outweigh the consequences just with respect to vitamin D, and that research is still need to be done, and is an area of great concern and is being prioritized now. As I said, the Race and Health Observatory, which is being hosted by the NHS Confederation, is going to be examining this area more specifically. And it's something, it's an area to watch and indeed to be involved in. I think it will be really important as we go forward that we don't just dismiss the racial differences as something that is going to be able to be managed just with a tablet, or with a dietary supplement. I say the vitamin D issue is a quick win. It probably does have benefits. There's very little downside to it. And certainly some evidence agreeing that it is protective. We do see higher prevalence of vitamin D deficiency in people of color. And certainly, pregnant women should be, having sufficient vitamin D, and young children probably also, again, not exposed to sunlight, particularly in lockdown, probably also ought to have vitamin D supplements. And we represent a risk group. And the NICE guidance certainly identifies Black people as being high risk and certainly should be taking vitamin D during the winter months. And I would argue probably during the rest of the year as well.
Thank you. From your experience as a secondary care physician or somebody who works in a hospital, what can be done by GPs or practice nurses to try and prevent more cardiovascular disease in ethnic minorities?
Well, I think it would be to, they're already doing the kind of blood pressure, they should be checking for diabetes, but I think it is incumbent upon themselves to recognize that there is this inequality and it's structural, and that racism is a part of that. And healthcare professionals of all ethnic backgrounds, will need to recognize that the way they approach different ethnic groups, the way they approach Black people, will need to be mindful that, we are always exposed, as you say, to the potential of these microaggressions and indeed overt racism and reduced access to healthcare for all sorts of reasons, discrimination, etc. And we ourselves should be and encourage our community to know their rights, what it is that they should be getting, when they go and attend hospital, the way in which conditions should be properly approached and managed, and to say, well, why aren't you dealing with this? Why aren't you dealing with that? When they go to hospital, and importantly, to the GP, to make sure they get referred as appropriately as they should, particularly with conditions like kidney disease. Sometimes GPs kind of dismiss it and say, oh, well, it's not that bad, not that bad. Well, it's when it's not so bad that it needs to be addressed.
Be careful, my ears are burning. I'm a GP, so. No, okay. Another question we have here is about, is there a reason why Afro-Caribbean people are more sensitive to salt?
Yeah, there's probably a number of, again, it's complex. There are probably genetic changes which do influence our propensity, and probably more so that for every, for want of a better word, excess amount of salt we have in our body has a greater effect in terms of impact on our kidneys and blood pressure and thereby heart disease. So there's one aspect. There is a view that our exposure to racism, again, chronic stress, cortisol levels also mean that we absorb and hold on to salt in high levels compared to other ethnic groups. And again, our cortisol levels may have been somewhat programmed by our racial experience due to slavery, yeah. And there have been theories proposed whereby particularly our ancestors' journey from West Africa over to the Caribbean set in play a set of changes such that those that actually survived were those that were able to be more salt retainers, yeah, and that helped protect them from the very adverse environment that they experienced, both while they were held in Africa, yeah, very often in holding, for want of a better word, pens or jails, yeah, and then the journey across, and then subsequently through their lives in slavery. And it may be that salt retention factor was actually protective, but now continues to have an adverse effect in the modern era and the post-colonial era. So I say there are many factors, things that still need to be teased out, is an area which probably requires greater research, and is an area of interest for some researchers.
Okay, thank you. You still have some more time for a few more questions?
Yeah, a few more minutes. I think dinner is not quite on the table yet.
All right, so this one is about, so someone's mentioned, I'm concerned about the prevalence and ease of access to fast food nowadays. Is there much thought about given to the effect of the type of food on the health of people, who, or they say hard-pressed people? I think, I don't know, I don't like this idea that Black people are always sort of hard-pressed or hard up or low earners. I mean, a lot of us in this group are doctors and we're not necessarily, but yeah, is there any truth to that in terms of diets of people who may be hard-pressed?
Yeah, I think there is, and again, it's structural. There is some evidence to suggest that if you compare the high streets in areas of relative deprivation, who will not so much by definition, but will tend to have a more kind of multi-ethnic makeup. Yeah, what you see on the high streets are availability of fast food shops, fried chicken, kebabs, sweet shops, and if every day that is the high street that you're walking down, yeah, and your choices are limited to that because that's where you are going to do most of your living and shopping, then that will tend to have an influence, particularly on our younger generation. I think it's too easy to dismiss the subtle effects of environment and advertising. But we know that advertising and what you see, yeah, definitely does influence what you do and what you eat. And I think, you know, again, I think the hopefully through the research being generated by the Raising the Health Observatory, we'll be able to influence policies in local government so that they don't direct and say, yes, you know, you can have a fourth fried chicken shop on your high street, whereas they wouldn't put that in a high street with you know, in a higher income area, yeah, and where the choices are generally more healthy. You might walk past somewhere that sells low-fat yogurt, you know. You might pass areas where, you know, you're more likely to see a salad bar, you know, in the front window rather than, you know, a beef burger. So these do have influences, and I think our choices are sometimes affected by people who have power over what can be put in our high streets. Oh, you've gone mute.
Sorry. What's the proximate life expectancy of a young person with very severe hypertension from an early age? I don't know if you might be able to comment on that.
Yeah, it's a difficult one. We know it's shorter. That's just a, you know, a general something, you know, we know, and as a result, knowing your blood pressure is probably one of those figures that one should be aware of. And increasingly, you know, we're now encouraging, you know, not just patients but people who, you know, to look after their health by having their own blood pressure monitor at home. And what one's looking for as well is for the change in blood pressure. So if your blood pressure is normal, yeah, over the years you want to be checking it, you know, maybe for a period of a week, maybe 3 times a year at least, noting down what your blood pressure is. And if you then start to see it rising, then to address that with changes, looking at your lifestyle, looking at the amount of exercise you're doing, the diet you're eating, what your weight is. But if it continues to rise, well, then one has to question again, what are the broader aspects affecting my health, but also question whether, okay, do I need to protect my health, and reduce my blood pressure through the use of medication typically? And that's something to discuss with your GP. And again, you know, one might want to take a lower threshold than what is commonly described as high blood pressure. And again, there may be some influence on policy that a blood pressure of 140 over 90 is really too high for somebody of color, and that maybe, given all the total risk that they're exposed to, you may want to start proactively lowering their blood pressure at a lower level.
Someone's here has mentioned, I've had a heart checkup about 2 years ago, and I believe they've had an ECG, and it says it shows incomplete right bundle branch block. And they said they were told not to worry about it. But after seeing this talk, I'm concerned about it again. What sort of external factors could affect this?
So incomplete or partial right bundle branch block is generally, certainly can be considered a normal variant. Hence why the view that it may have been somewhat, you know, dismissed. It's important that clearly, if the ECG has been done for symptoms, and particularly if the ECG is repeated and it seemed that there have been changes, and in fact the right bundle branch block is new, then that might be an indication of more right heart disease, in particular pulmonary vascular disease. And so it's something that needs to be taken seriously. But if it's done, you know, if somebody's clearly had an ECG, often, you know, in their kind of early 30s, maybe sometimes, you know, for insurance purposes, then very often there isn't anything to be worried about. But if it's, like I say, the ECG's been done because of health issues, then it might be that the ECG needs to be repeated to be certain that it is something that is a normal variant and is something not to just be dismissed.
Oh, thank you. Another question here, really important. Do we as a group present too late?
In general, we do, yes, for various reasons. Again, because of general, our experience of healthcare, the fact that you may not want to go and see that particular GP that you had a bad experience with. I'm sure, Dorian, you're fantastic. But if you don't have a good relationship with your GP, then that can be difficult. Particularly if you're not sure which GP you're going to see, you may delay until you can see that that particular person. But I would urge I would urge anybody, if they have a health issue, to get it checked out. And certainly, of the patients that I see privately, they would very easily say, well, I've had a little flutter, and they will want to see a doctor straight away. Yeah, it may be nothing, but they've got it checked out, and if it was something, they've got it dealt with early. So it's important. So certainly, if an issue occurs, particularly if it's recurrent, or if it's not going away, then don't hesitate. Go and get it checked out. That's what your GP is there for, and that's what the health services are there for. And it's better to get it seen early, and and if appropriately reassured, that's great. Sometimes time is a great healer, and things settle down. One has to again recognize that it may be stress related, but again, one can't be absolutely certain, and it's important that it gets checked out and, if necessary, monitored, so that if it is stress related, then the stress is sorted out, and it may be appropriate to refer you on for, whether it's stress counseling or help with dealing with some of the effects of the stress itself.
Okay. This is a slightly more technical question, probably asked by one of our fellow doctors, but it says, why are Black people prioritized to be given calcium channel blockers, which is a type of medicine commonly used to treat high blood pressure, whereas Caucasian people are offered ACE inhibitors, which is another type of medication used to treat high blood pressure?
Yeah, so that's a good question. In general, and this is a generalization, the high blood pressure in Black people tends to be described as low renin. So it's often high blood pressure associated with increased blood volume as a result of salt retention. And so, again, it's a generalization. If you want to hedge your bets about reducing somebody's blood pressure with the most effective agent possible, hopefully with one tablet, then in a Black person, you'll pick something that will reduce or will influence the low renin status. And we know that calcium channel blockers do that better than ACE inhibitors, and Black people respond better to calcium channel blockers, and in general, diuretics. So the nice guidance in the British Hypertension Society would suggest in Black people to start them on a calcium channel blocker first, but then if they do need additional therapy, the next step would generally be one of the renin, angiotensin, aldosterone system blockers, of which an ACE inhibitor or an ARB is what's recommended. And what often is also sometimes used is spironolactone. So this is an old drug which has kind of found its feet again, and again in low renin status patients, spironolactone has quite dramatic effects at reducing blood pressure and reducing blood volume, and is probably It's old. It was classed as a diuretic, and diuretics have again shown particular benefit in patients with black parentage. And it's because of the particular nature of the hypertension why calcium channel blockers and diuretics such as spironolactone are probably more beneficial in our community.
I think there are so many different medications that can help to treat blood pressure. I always think that, you just have to use the one that works best for your patient, because if your patient doesn't like it, it gives them too many side effects, they're not going to take it anyway. So give them the one that brings down their blood pressure and has the least amount of side effects.
Yeah, and as and to add to that, it's probably worth sometimes kind of alluding to the possibility you might need 2 drugs. Yeah, but actually you're better off going with low or medium doses of 2 drugs rather than a high dose of 1 drug. A high dose of 1 drug will often be associated with side effects, and I'm sure you're aware, Dorian. Many patients who are on, for instance, 10 milligrams of amlodipine will almost always get some ankle swelling and leg swelling, whereas you very rarely see that at 5 milligrams. So very often I would tend to go with the 5 milligrams and then come in and add in another different agent, be it an ACE inhibitor or a diuretic. So that's where the two often complement each other, and you often help to reduce the side effect of one by using a low dose of another tablet. So that combination therapy is great, and people shouldn't think about it as being, oh, I'm now on a second drug. Very often combination therapy is the better way to go.
Thank you so much, Dr. Martin. It's been really informative talk. I've been a doctor for many years, and there's still things that I'm learning every day. And I think that's something that happens in medicine, that you can still learn something new. And I hope everybody has enjoyed the talk that you've given today.
Thank you.
Thank you very much.
We're only really touched on the surface of certain things. So, like I say, very, very happy if come back and do a more in-depth talk about high blood pressure, coronary disease, and also other colleagues who can talk on other aspects of heart and other conditions as well, diabetes indeed. I'm sure I can find other colleagues, and I'm sure Rochelle knows colleagues who I'm sure will be very eager to kind of spend some time with the organisation and with the audience. So I say thank you very much. It's been a pleasure and an honour. And I wish the organisation every success and for the future.
No, thank you so much. So we are really just getting started out with our health promotion work. And this is just one in a series of talks that we're going to be holding over the next couple of months. And we hope to ramp up that work over the coming years. We really appreciate anybody who's already donated to our organization so far to try and help us keep going and keep giving you the best information and producing great content for you. If anybody wants to go to any of the links that have been posted in the chat, please copy them down. And thank you for taking your time out on a Saturday evening to be with us and come to learn about your heart and your health. And thank you to Dr. Martin. Thank you to the team in the background, everybody there who's been helping to post all of the questions and answer all of the questions, and everyone who's asked questions. I hope I've asked everyone's question. And I don't know if you want to put up your slide again about how to contact you privately, in case anybody had additional questions or people had wanted to look at it, because I think there was a question about private practice. I didn't specifically ask it, but I said that I'd put up your detail. You could put up your details there so they can contact you.
And like I say, now with Zoom, things are a lot easier. So it doesn't necessarily mean you have to travel to see me in Kent. Very happy to have a consultation if needs be over one of our video platforms. So yeah, very happy to help out.
Thank you so much, Dr. Martin.
Have a good evening, everybody, and thanks again.
Good night, everyone. Take care. Please follow us on all of our social media. We're on LinkedIn and Twitter and Instagram. And on Facebook as well, I think. If people are still using Facebook. All right, good night, everyone.
Cheers.
If anybody did have any additional questions, please feel free to email us if you wanted to keep in touch. Send us an email and we can keep you, informed of any future events that we're going to hold. So, and again, thank you for everyone for joining us this evening, and look forward to seeing you at the next event.